And with that, I'll end, and thank you very much.
Thank you very much, Dr. Sharon, for your talk. So I think we run out of time, and we will move to the final section in this morning. And the next section is a hepatitis B infection, which is also a serious and deadly disease. The next speaker is Dr. Sharon Lewin. She is a professor of infectious disease at the University of Melbourne and inaugural director of Peter Doherty Institute for Infection and Immunity. She leads many multidisciplinary research on HIV and HBV infection. Her topic today is a hepatitis B cure. Please welcome Dr. Lewin.
Thank you very much for the kind introduction, and a great pleasure to be back here in Bangkok. I've been coming to the HIV-NAT Symposium for probably close to a decade, so it's wonderful to see it getting bigger and bigger, and particularly to see so many Thai presenters as well. I think most of you know that I primarily work on HIV cure, but the expertise on HIV cure is so strong in Thailand that I don't need to talk about that here, and I've been given a different topic, Hep B cure. I've done a lot of work on HIV-HBV co-infection almost entirely in Thailand with Anshali Avahingsanon. But I also have a very strong interest in hepatitis B, and particularly cure. The Doherty Institute supports now a very significant global effort around Hep B cure that I'm going to tell you about today. So I think everyone in the room will be very familiar with this map showing the prevalence of HIV globally, the burden of the epidemic in sub-Saharan Africa, and a significant burden, of course, here in the Asia-Pacific region with 5.9 million people living with HIV. Now, if you look at a similar map of the global prevalence of hepatitis B, it's almost identical and can be superimposed on the map of HIV, again, with actually very high prevalence in Africa, which is often overlooked, and a very high prevalence in the Asia-Pacific region, largely due to the prevalence of hepatitis B in China. 266 million people living with hepatitis B in this region, which accounts for about 80% of people living with hepatitis B globally. Now, I'm not going to talk much about co-infection today, but a very nice systematic review published just a couple of months ago in Clinical Infectious Diseases telling us that the global burden of HIV-HBV co-infection is about 8% of people living with HIV. So cure in hepatitis B is very important for many of the people you care for as well living with HIV. Now, I think lots of you know about the big effort in finding a cure for HIV. This has very much been led by the International AIDS Society, who have been leading the global strategy on an HIV cure since about a decade ago. Of course, many other agencies fund and promote and support HIV cure work, particularly the NIH and AMFAR, but a global effort very much led by the International AIDS Society. What you may not know is that a similar effort is now happening for hepatitis B cure, a global scientific strategy for hepatitis B, very much based on what we did for HIV, was published in Lancet Gastrohepatology earlier this year. And in the Hep B world, they don't have an international organisation similar to the IAS, but something called ICE-HBV, the International Coalition to Eliminate Hepatitis B Virus, was established about 5 years ago. A number of partners, primarily funded by the Doherty Institute and the ANRS, but in partnership with other agencies, now trying to accelerate this effort in hepatitis B. So I'm going to talk to you a little bit about the natural history and current treatment of chronic hepatitis B so you understand why there is this interest in finding a cure, the potential impact of an HBV cure on HBV incidence, what those barriers to an HBV cure are and why antiviral therapy doesn't cure HBV, the definitions and goals for work in an HBV cure, and just a little bit about the clinical approaches being tested. And this is an unbelievably active field of research currently. I was saying earlier that with the cures now available for hepatitis C, most companies have now changed their efforts to hepatitis B, so a lot happening in that space. And I'll give you a sense of some of the excitement around the development of novel interventions for hepatitis B cure. So I think, as everyone here knows, we diagnose chronic hepatitis B infection by the persistence of HB surface antigen for at least 6 months. At diagnosis, nearly everyone will be HBe antigen positive as well, but a number of people will lose E antigen over time. Hence, we have chronic HBV infection that can be E antigen positive or E antigen negative. People have detectable and high levels of HBV DNA, and their ALT may be normal or abnormal depending on the stage of disease. And current recommendations for hepatitis B are to treat individuals who have an abnormal ALT. In co-infection, we treat everyone with hepatitis B. Now, as soon as you start treatment, which includes nucleotide reverse transcriptase inhibitor, a flare, and then over time, S antigen will persist and E antigen will persist. However, in some individuals, they'll develop antibodies to E antigen. It occurs at a rate of about 5 cure. If you develop antibodies to surface antigen, most people would recommend you can safely stop antiviral therapy. So we have excellent treatment for hepatitis B. It's widely available, it's cheap and effective. The recommended initial treatment regimens differ across the world, but are not too dissimilar here in Asia. The Asia-Pacific Association for the Study of Liver Disease, or APASL, recommends either entecavir, an NRTI, nucleoside reverse transcriptase inhibitor, or tenofovir. EASL, the European Liver Association, recommend entecavir, tenofovir, or TAF, as does the US guidelines. And in general, for most people, whether you're E antigen positive or negative, treatment is lifelong. Some guidelines recommend that nucleoside treatment can be stopped in E antigen positive individuals if you've 2 years after treatment, 2 years following E antigen seroconversion. I told you that's quite rare. Or an E antigen negative disease, you can stop once there's a normal ALT and DNA less than the lower limit of detection. But relapse is high in these individuals, and about 70% will need to restart NRTI treatment within a year. Just to remind you that the guidelines for HIV-HBV co-infection are quite different. We treat everyone with hepatitis B, regardless of whether they have an abnormal ALT or not, and treatment means the incorporation of both tenofovir or TAF together with either lamivudine or FTC as a backbone to ART. So different recommendations in co-infection compared to HBV monoinfection, where treatment includes dual nucleoside treatment against hepatitis B. So treatment is good, it's cheap, it's effective, but it's far from ideal. And first of all, only about 25 to 30% of people living with hepatitis B are eligible for treatment, meaning those that have an abnormal ALT. Nucleoside treatment does not eliminate completely the risk for hepatocellular carcinoma, so lifelong follow-up is required. Lifelong treatment comes, of course, at a cost, which we are well familiar with in the field of HIV. There's the risk of non-adherence, the risk of cumulative toxicity, bone and renal disease, again, all which you'd be familiar with the use of tenofovir. And stopping antivirals in the setting of hepatitis B does lead to viral rebound at an unpredictable nature, and therefore risk of transmission, and also, if untreated, a risk of severe hepatic flare or abnormal liver function tests. Now, the global uptake of antivirals for hepatitis B is very low. These slides remind me a little bit of what we just saw for TB. In 2016, the WHO set an agenda for the global elimination of hepatitis. Their targets for 2030 to achieve elimination of hepatitis B amongst other targets, include that 90% of people living with hepatitis B should be diagnosed, 80% who need treatment receive it. And this is a wonderful review from Dave Thomas in the New England Journal of Medicine early last year, showing that we are far from those targets. In 2015, you can see here what's happening in the dark blue. In light blue is the 2030 target. So in 2015, the estimates are that about 260 million people infected with chronic hepatitis B. About 22 million of them are diagnosed. So a huge problem with diagnosis and testing for hepatitis B. And about 1.7 million people who need treatment are currently on treatment, way beneath any of the targets set by WHO. So a very long way to go in implementing hepatitis B treatment. So given treatment uptake is so low, and we also have an effective HBV vaccine, what difference would a cure make? And there's been a little bit of modelling on this topic. I think there needs to be more. And one model predicted that a cure for hepatitis B, meaning that a finite period of treatment, not lifelong treatment, would accelerate a modest decline in HBV incidence, but most importantly would significantly reduce costs. So this is the model that looked at the effects of increasing infant vaccination to 90%, ensuring that birth dose is given to neonates, to 80% of neonates, that there's a use of peripartum antivirals, that's the PPT here, to 80% of HBe antigen positive mothers, and population-wide testing and treatment to 80% of eligible people. So a lot of interventions are needed to reduce HBV incidence. You can see that each of these give you a progressive decline in HBV incidence with an additional effect of cure here in blue, which is quite modest. But if you look at the impact on costs of delivering these interventions, the impact of cure is quite significant. In the solid line is if all of those the cost of all of those interventions in the absence of a cure, and in the dotted line, all of those interventions in addition to a cure. Blue, global costs, red, low and middle income costs, and you can see this very profound decrease in cost required should we find a way to treat people with HBV for a finite period of time. So, what are the barriers to a cure for HBV, and why has it been so difficult? And I'm sorry, but I'm going to have to give you a little bit of a virology lesson on hepatitis B. Many of you in the room, I know, still are struggling to get your head around HIV virology, and I assure you Hep B virology is 10 times harder. But I want to just give you a simplified version of hepatitis B life cycle so you can understand the principles of why we don't have a cure. So hepatitis B is a DNA virus. It primarily infects hepatocytes. It uses a recently discovered receptor called NTCP to enter the hepatocyte. Once it enters, it uncoats, like many viruses do, including HIV, and releases its genetic material into the cell in a form that we call relaxed circular DNA. That relaxed circular DNA enters the nucleus where it forms a very critical structure called cccDNA, covalently closed circular DNA. Now this is the major barrier to a cure. It's actually extrachromosomal, not part of the DNA, but it forms what's called a mini chromosome, so a structure that can survive outside our DNA but within the nucleus. And the cccDNA basically forms the template for HBV, and it does this by transcription, DNA to RNA first, through something called pregenomic RNA, and this forms the template. This then undergoes reverse transcription, very important step here, identical to HIV, but it occurs late in the phase of the Hep B life cycle. So you go from RNA to DNA to viral production with this step of reverse transcription, and that's why reverse transcription inhibitors work. But it also has this very interesting recycling component of the HBV DNA so ongoing production can feed back and replenish your cccDNA. cccDNA also produces a completely separate RNA structure called pre-S1 and pre-S2, and this is the template for Hep B surface antigen. So this shows you very clearly that to produce new particles, you need DNA and you need S antigen, but if you just block reverse transcription, you don't do very much to HBs antigen production. So on current treatment that you're all familiar with, tenofovir, lamivudine, FTC, you can block all of these steps, but you can't block ongoing production of surface antigen. Now, why is that important? Well, in addition to that, HBV can actually integrate into the genome. Similar to HIV, it occurs at very low frequency, and it's unclear how important this is for rebound, but certainly important for risk of malignancy. Now, why is production of HBs antigen important? Well, first of all, there's bucket loads of antigen pouring out of hepatocytes, even when people are on treatment, and it's produced at vast excess over virions, about 3 to 4 logs greater amount of antigen compared to virions that you produce. And it's important because all that antigen basically exhausts the immune system. And there's been many studies looking at the immunodampening effects of S antigen. It can suppress innate and adaptive immunity through altering TLR signaling. It alters interferon alpha production, dendritic cell and T cell function. So by reducing surface antigen, you can enhance your capacity for seroconversion. Now, what is being attempted, or what are the definitions and goals for an HBV cure? Well, basically, it's a very similar approach to what we're thinking about for HIV cure, that we at least will give a finite period of treatment, maybe 1 to 2 years, that will achieve HBs antigen loss, and that it will be effective across all phases of chronic HBV infection. So currently we only treat people with chronic hepatitis B who are E antigen positive and E antigen negative with an abnormal ALT, but we don't treat people with a normal ALT who are E antigen positive or E antigen negative, and the idea here is that a cure would be available to all individuals living with HBV. Now, here are some of the definitions. Again, a bit similar to the thinking in HIV. The hepatologists are still talking about functional cure. I hate that term. I think it's a really confusing term to the community and to many physicians. I prefer the term remission. Then there's the option of cure, and then the hepatologists have added in this additional concept of a complete sterilising cure. Now, the goal of all of these strategies are to eliminate S antigen and HBV DNA, as well as eliminate liver disease. However, in a functional cure, you may still have some cccDNA present, you may still have integrated HBV DNA, so therefore there is a risk of reactivation should you be immunosuppressed for cancer chemotherapy, for example, and you will need ongoing monitoring for HCC risk, because having any cccDNA or integrated HBV DNA will still put you at elevated risk compared to an uninfected individual. When they think about cure and sterilising cure, it's really about whether you can eliminate cccDNA entirely, whether you can eliminate integrated HBV DNA, and if you're able to eliminate both, this will eliminate your risk of reactivation and lifetime monitoring, but may not be required to have a big impact. But this is the holy grail of HBV cure. So what clinical strategies are being tested? Again, very similar concept to what we're doing in HIV. This is to reduce the amount of persistent HBV, HBV DNA, surface antigen, and that mini chromosome, the template for Hep B cccDNA, and at the same time enhance the immune response, which in hepatitis B has a really very good rationale, which I'll explain to you later. So what are the strategies used to reduce hepatitis B? And there are a lot out there that are now in phase 1 and phase 2 studies. So here's the diagram I showed you earlier about production of HBV DNA, production of S antigen off different transcripts, and the recirculation of HBV DNA within the infected hepatocyte. This is where the NRTIs work. I've already shown you blocking reverse transcription. So the additional interventions to reduce hepatitis B include entry inhibitors. Mercolex B was actually developed for the treatment of hepatitis delta, also has activities of hepatitis B entry, and can potentially contribute to a cure if there is ongoing infection of hepatocytes with hepatitis B. There's a huge number of these drugs in development called capsid inhibitors or capsid allosteric modulators, and they have an interesting function in both blocking viral production but also blocking recirculation of HBV DNA. And these are all targeted at blocking viral replication. There's a whole nother series of compounds that are just targeted at reducing your S antigen load to enhance seroconversion. And they include a wide range of compounds that block translation, and they include RNA destabilizers, siRNA, transcription inhibitors, and linked nucleic acids. Loads of compounds being developed, compounds that block S antigen production, and then, of course, gene therapy targeting destruction of cccDNA. And I'm just showing you this slide, which gives you a sense of how engaged industry is in hepatitis B cure. These are all new compounds currently in phase 1, phase 2 development, and I'm just going to talk briefly about a few of these. One example of a CAM, or a capsid allosteric modulator, one example of siRNA, and briefly on S antigen inhibitors. So capsid inhibitors have got these two sites of action. Their primary mechanism is interfering with capsid assembly, so will block viral production, and their secondary mechanism inhibits capsid disassembly and therefore potentially reduces this recirculation of HBV DNA. There are loads of capsid inhibitors or CAMs on the market being investigated. Here's some recent results from 4 of them, all showing that they can reduce HBV DNA. So they clearly block viral replication. They block viral replication quickly because this is what happens in the first 4 weeks. Some interesting data recently presented on this compound, ABI 731, and full details of its safety were just published a couple of weeks ago in Lancet Gastrohepatology. But if you give this compound for a longer duration, for 76 weeks, in fact, it was observed there was a mean HBV DNA decline of 6 logs, a mean HBV RNA decline. I haven't told you about HBV RNA, but you can measure HBV RNA in circulation, and it's a surrogate for cccDNA, what's happening in the liver, and a reduction in surface antigen. So this is pretty impressive activity of this secondary mechanism of a capsid inhibitor. What about inhibitors of transcription and translation? Well, siRNA is in the clinic for hepatitis B. You may not realise that. I think many people with HIV think siRNA is decades away. It's in the clinic and it works well in hepatocytes because it rapidly uptakes the delivery molecule for siRNA. Now, this is what the genome of hepatitis B looks like, and where you design your siRNA pros will depend on what transcripts will be blocked, but the main goal is to block production of S antigen. This is an example of one siRNA produced by Johnson & Johnson given subcutaneously, and you can see in this dose-finding study a significant reduction in Hep B surface antigen. Remember, this doesn't happen with NRTI inhibitors and very limited toxicity. You can also block production of HB S antigen through inhibiting something called subviral particles. This is done by these interesting compounds called nucleic acid polymers, and they can inhibit S antigen release, reduce intracellular surface antigen, They don't actually work on DNA, so they'd be used in combination with the nucleoside. And in a recent clinical trial, together with tenofovir interferon, after stopping treatment, there was a reduction of Hep B surface antigen in 40% of participants, essentially a functional cure. What is being done with respect to enhancing the immune response? Well, this is very analogous to the principles in HIV, and I love this analogy that comes from a very nice review article from Marla Miani, who talks about ways that we can boost immunity. And there's excellent rationale for this. First of all, existing antiviral approaches are unlikely to eliminate every trace of hepatitis B, including cccDNA and integrated virus. We need the immune system as well. Most infected adults resolve Hep B on their own by developing an appropriate immune response to the virus, making Hep B surface antibodies. So this is really the blueprint for immunotherapy. We do not have examples such as this in HIV. Even when chronic infection is established, immune control is possible in a small group of people. There is a biomarker for cure in people on treatment, and that's S antigen seroconversion or development of antibodies to HBs. And one concern of immunotherapies, particularly if it boosts T cell function, is exacerbation of liver disease. So this is the analogy that I like of reviving or replacing the immune response. So revving up the immune response means activating what's previously suboptimal endogenous responses, effectively putting on the gas. TLR agonists are an example of that. Reviving and replacing exhausted endogenous responses, immune checkpoint inhibitors do that, essentially releasing the brake on the immune system, or replacing the immune response through new endogenous responses such as therapeutic vaccination, which I have to say has not worked in hepatitis B. However, new exogenous responses such as CAR T cells and antibody infusions are being tested, essentially completely replacing the old model with a brand new immune system. And I'm going to give you a couple of examples of revving up and reviving the immune response. So revving up the immune response, probably the lead compound that does this, it looks quite effectively, is a TLR8 agonist, GS9688, made by Gilead. Slightly different function to TLR7 agonists that you would have heard about in the context of HIV. So this trial in both viremic and aviremic individuals randomised people to receive either nucleic NRTIs or nukes alone, together with the compound at 1.5 milligrams or 3 milligrams for 24 weeks. And then everyone was placed on an antiviral. And this just shows you the inflammatory response to the TLR8 agonist, production of some inflammatory cytokines, IL-1, IL-12, interferon gamma, a clear dose-dependent pharmacodynamic response to the TLR8 agonist, so doing something to the immune system. And this is what it did to surface antigen levels. This is a waterfall plot commonly used in outcomes for malignancy, but a nice way to show S antigen decline or increase, one of the goals of outcomes of cure. You can see the sort of declines you get in the placebo arm, and look at the declines you get in e-antigen negative, e-antigen positive disease at low dose in green or high dose in blue. Quite impressive S antigen loss. And ACTG are actually now designing a study of GS9688, TLR8 agonist in HIV-HBV co-infection. I hope very much that this study will be available in Thailand. It will be the first HBV cure study in co-infection. What about reviving the immune response? Anti-PD-1 is the lead way to do that, using nivolumab. And in this study, it was done with or without an HBV vaccine. The study was led by Gilead. It included participants with chronic HBV infection on a nuke, entecavir. They had suppressed viral load, and they received a single low dose of nivolumab at 0.1 or 0.3 milligrams per kilogram. The licensed dose is 3 milligrams per kilogram, so this is a tenth of the dose of PD-1 with and without an HBV vaccine, and looked at S antigen declines. And in red is PD-1 alone, in blue PD-1 with the vaccine, and at week 12 and week 24 you can see there are quite significant S antigen declines in both arms, suggesting that PD-1 was doing the work here, not the vaccine. There was one individual that had a significant flare and a sustained S antigen seroconversion. And what was of high interest was this very high receptor occupancy from low-dose PD-1, which gives us hope potentially of using this strategy in HIV. A single low dose of PD-1 within a week gave you 80% occupancy that lasted between 6 to 12 weeks. So the future of hepatitis B cure is looking at combination treatments that inhibit replication. I gave you an example of the capsid inhibitors that reduce antigen production. I gave you the example of siRNA, and also combined with immune stimulants. There's lots of permutations and combinations of how this is going to be done. These are the combination studies that are already in phase 1, phase 2 development, all the different combinations that are currently being tested. So in summary, the main barriers to cure, if you remember one thing from the lecture, is that it's the persistence of hepatitis B in two forms, cccDNA, the template for hepatitis B, and ongoing persistent high levels of surface antigen, combined with immune dysfunction on long-term antiviral therapy. Sounds familiar. It's almost identical to how we describe the challenge with HIV. There are many strategies to reduce HBV replication and surface antigen production. I gave you several examples of these. Combination approaches will be likely needed. Multiple clinical trials are underway, and the key concern here is to minimise liver damage, particularly with an enhanced T-cell response. And finally, and this is really the distinguishing feature between hepatitis B cure and HIV cure. In hepatitis B, we have a biomarker for cure, that's S antigen seroconversion. The concept of functional cure we know occurs in a small group of individuals. And because of that, this has led to a very high level of industry engagement and a very high optimism that a Hep B cure will be achievable. And I just want to thank a number of people who provided me with slides, particularly Ed Gain, a wonderful hepatologist from New Zealand, Anna Kramvis from South Africa, Marla Maini from London, and my close colleague Peter Revel from the Doherty Institute in Melbourne. Thanks very much.